Shapiro's eye movement desensitization and reprocessing therapy, I was enormously skeptical of it. I still remember a couple of stories that still very much bother me. And yet, I would just say this, EMDR was probably the most powerful modality that I used. Just think, that's when I remember why I'm so fortunate to do this work.
What is going on, fam? Welcome back to the channel. My name is Phil Sarpon. This is Phil's Guide to Psy.D. This channel is dedicated to all things psychology, wellness, and graduate school. I know I say this every time, but today we have a very special guest. His name is Dr. Adam Dell. He's a clinical psychologist and he specializes in all things trauma and PTSD. From 2020 to 2024, he served as Director of Emotional Wellbeing at the Notre Dame Wellness Center with Premise Health. And then from 2014 to 2020, he served as an active duty psychologist with the United States Air Force. He draws on about 20 years of clinical experiences to offer insights and practical solutions with his audience. He does a fantastic job of combining exercises and information into seminars to maximize engagement and impact in terms of educating the public on what trauma is all about. I am super excited to bring him onto the podcast and onto the channel because I think he's going to provide a really valuable insight into what trauma actually is. Trauma is kind of a buzzword and what you can do about it as a clinician or even as a future clinician. So if you are interested in becoming a trauma-informed therapist or psychologist, learning things like cognitive processing therapy, written exposure therapy, EMDR, we go into all of that into today's podcast and episode. All right. So before we jump into that, I do want to mention if you want to follow me at Phil's Guide to Psy.D, the Phil's Guide to Psy.D community on Instagram has been growing. And so if you want to support my podcast and channel there, you can definitely support me there. The other thing too is that you can also join by becoming a member. By becoming a member, you get insights into all of the episodes that we have not released yet, as well as some behind the scenes content as well. So you can always support me through there as well. All right, so without further ado, let's just jump right into it. All right, Dr. Dell, good to see you. How are you doing today?
I'm doing well, sir. Thanks for having me on.
Absolutely, and I really appreciate the time. I think we'll just jump right in. Love to know about your experience and your work in the field of PTSD. If you want to just kind of give me and the audience a little bit of an overview of that.
Okay, first of all, I had this host in class, and he's a stellar student. So it's good to see a man on this side. Work with PTSD, as a graduate student, I was very child and adolescent focused. My dissertation was focused on the assessment of psychopathology in kids, particularly externalizing disorders like ADHD or oppositionality. I was exposed at that time to cognitive behavioral therapy with a trauma-focused lens for kids. Which is pretty widely used and is an evidence-based approach to treating trauma in children. I was fascinated by that. It came sort of in a manualized form. And so it taught me basic principles of exposure and doing that in a way that's respectful of not only kids, but also their guardians. And so learned a little bit about that. And then kind of unexpectedly, when I was applying to internships, I threw my hat in the ring for an Air Force internship as an active duty person. And I got in somehow. I mean, I should not have. In fact, all their billets were filled that year. And so when they accepted a joker like me, and it actually meant that somebody who was promised a spot, who was a scholarship participant, was deferred for a whole year. But anyway, I mean, I just am so thankful that I got in there. And that's really where I did major rotations in PTSD clinics, very much focused then on adults and that population, combat-related trauma, sexual assault, and really various forms of trauma. Sometimes individuals in the services would experience a traumatic event overseas or in a unit or even just as civilians in their neighborhoods. And that would reawaken even, trauma from childhood. So Had the opportunity to have extensive training in things like prolonged exposure, cognitive processing therapy, in individual and group formats, and then to do kind of group supervision with 12 other psychology residents, or I made 12, so 11 other residents and supervisors in an actual PTSD clinic. So that was kind of my introduction to it. Along the way, over the course of my Air Force career, thanks to taxpayers like you, I had the chance to get trained in other modalities, such as EMDR. I did that as an officer. Written exposure therapy, something I picked up along the way as well.
Wow, what a really extensive experience and career that you've had so far. I think when I think about trauma, I feel like trauma has definitely been a buzzword in the last few years, and I've definitely seen it a lot on social media, and which has been great because I think the awareness for trauma has been a lot more on people's minds. And on the other side of things, I feel like there might be some misinformation about trauma, what it is, what it isn't. Could you speak to that a little bit in terms of educating the public on what trauma actually is versus what it's not?
Sure. Yeah, man. Sure. So I'll tell you what. There's well, boy. There's a lot. There's a lot to unpack there. I guess a few things that would be, maybe critical to know. And for someone maybe that is watching this and they don't have, they're not on the tail end of their doc program like you are. Our diagnostic manual that we use to diagnose things like depression or anxiety is actually pretty specific about what a traumatic event is. And I don't have them. I don't have all the criterion memorized, but it actually requires that someone is exposed to death or dying or severe injury, a severe assault. And in the more recent iterations of that diagnostic manual, it's even vicarious exposure to that, meaning, frankly, dude, like you are going to have a ton of trauma exposure if you choose to be a psychologist who sort of listens to the stories of trauma. This is one of the reasons, actually, why I think psychiatrists have very high suicide rates. At least, there's a good hypothesis to be made that they are worn down and in some ways psychologically harmed by repeated exposures to trauma for people that they care for, that they're entrusted with helping. Now, after that, there's all kinds of symptoms that will emerge. And one of the no kidding ones that is non-negotiable is avoidance. People that experience a really big trauma, and sometimes those diagnostic level traumas are called capital T traumas. And then, something that might be difficult that doesn't fall into that bucket might be a lowercase t trauma, that you hear that kind of differentiation in pop culture or social media. For a very small minority of people who are exposed to one of those major traumatic events, they will develop symptoms that last longer than 30 days. And it's actually, the human condition is remarkable. I mean, so if you think about like who's more vulnerable than a young child, kids don't have a lot of agency. They don't have a lot of life experience. They don't have a lot of coping skills, presumably, or whatever we might think of as protective factors. When kids in global epidemiological studies, looking all over the world, when they're exposed to one of those capital T traumas, things like a natural disaster, combat-related type trauma, refugee status, this type of thing. Over 50% of kids that are exposed to a big T trauma never develop any kind of clinically significant symptoms. And the next 25%, which would bring it to about 75, almost 80% of all the kids that are exposed to a big T trauma like that might be exposed to it and have some symptoms, hypervigilance, exaggerated startle response, a little anxiety, maybe some insomnia, but within 30 days, assuming that they're not repeatedly, continually exposed to something traumatic, they return back to baseline. So really, when we think about PTSD, or post-traumatic stress disorder, we're talking about, the remaining 25% of people, children, adolescents, adults, geriatric population, when exposed to trauma, they're truly haunted by symptoms like re-experiencing the trauma in sleep time or wakefulness, intrusive painful memories, patterns of avoidance, changes in thinking, changes in emotional status, etc. That's what we mean by someone who is traumatized. But I guess I know I'm kind of ranting at you, and I apologize for it. The same epidemiological studies that say, hey, look, the vast majority of people, when they are exposed to trauma, do not have a life sentence to these symptoms, also would suggest, based on global studies, and I tend to look at the International Society for Traumatic Stress Studies because it's not only looking at the West, they suggest that over the course of the average lifespan, we all will experience around 3 of these capital T things. Someone that we love could die in our arms, or there could be a very catastrophic motor vehicle accident, or a loved one could die by suicide, or we could be the recipients of vicarious trauma when our children explain to us that the unthinkable has unfolded in their life, or we experience a sexual assault, or we experience childhood sexual abuse, etc. So, I think the hopeful message and the thing that I try to share a little bit, certainly like in our course that we had the opportunity to learn together in, or when I'm given the opportunity to speak at a conference or in social media, it's kind of, I think we are a culture that is aware of the fact that trauma can have a pernicious effect. It can certainly have a cumulative effect over time, and so it's intuitive, and certainly the clinical literature bears out that if somebody's exposed to one trauma and doesn't have a lifelong after effect from that's negative and impairing, if that person is repeatedly exposed to that kind of a stimulus over time, there's a cumulative weight associated with it. And we all know about post-trauma stress. We've seen movies or shows. We have friends, maybe, working in a VA, that this is something that's a fairly common diagnosis. I think what we maybe are less familiar with, but probably is more common, is post-trauma growth or resiliency. And so, I just think the resiliency pathway is the most common thing that we might expect if we had to guess after someone experiences trauma. Not that the trauma was good, not that they like the remembrance of it, but that largely they're not derailed by it and they get to move forward in their life. And then post-traumatic growth is just this beautiful phenomenon where for some people who are especially harmed by trauma, they actually become wiser, kinder, more able, more flexible, more spiritually sensitive versions of themselves. And there's many domains that look at post-traumatic growth, and that's some of them. It's an undeniable reality that has been studied all over the world. And frankly, dude, it is the highlight of my career, I think, to, lots of people come to therapy because they've experienced something traumatic and they don't know how to make sense of it. And sometimes, although I'm a bit of a skeptic in terms of how much of an agent of change I actually am in the process, when someone experiences healing or sets off on a pathway that looks like one of the domains of post-traumatic growth, I just think that's when I remember why I'm so fortunate to do this work.
I love everything that you said, and I want to also highlight some of the things that struck me. Is that from the research, and I think also the literature and the evidence, is that even though a majority of people can go through trauma, it doesn't mean that necessarily be traumatized. And I think that in a sense is pretty remarkable. And that even for the people who do get traumatized, the treatment that we have, the evidence-based treatments that we have, there's still hope. And they can still go through that treatment and still get recovery and healing from it. And so there's a lot of hope, I think, in what I'm hearing. And I also think, too, despite the trauma, there is hope and potential to even have a newer or a deeper sense of life and meaning that you had before. Transition to talk about the treatments, specifically written exposure therapy.
Yeah, so for decades, we've known that exposure tends to be helpful in ameliorating, maybe not altogether, but significantly reducing distress about something that's feared. And so, listen, most people are aware, like for example, maybe you've seen a video of it. If you haven't, it's worth taking a look on the internet. Like individuals with a spider phobia, for example, that go to an exposure clinic and you do graded exposure with that. And so somebody's looking at a picture of a spider, and then gradually they take steps in the direction of greater real life exposure to that feared stimulus, until eventually 3 hours later, there's like a tarantula crawling on their head. And it's like, wow, that's amazing. We've known that exposure kind of helps reduce fears. And when things like phobias are literally paralyzing for someone's functioning, exposure is actually way more effective than medication or other things that might have been tried. And so when individuals experience a traumatic event, typically the memories of what occurred are encoded in very sensory details. So if you talk to someone, or if you've had experience in a trauma, there's almost like flash points of remembrance of things, what things smelled like, what you may have heard, what you may have smelled, what you were feeling. You might even have real vivid flash points of something you were thinking. Or, I can't tell you how many times I've interacted with someone that was in a serious assault situation or a life or death situation, and all of a sudden they just became intensely aware of what the microfibers in the carpet felt like, or the smell of something. And so basically, because trauma is definitionally, disturbing, and also because many people who experience a traumatic event have never experienced anything like that before, it's really hard to make sense of it. And so many of these vivid and frightening sensory details from memory basically just get kind of fragmented, and people avoid thinking about it if they can. And in fact, avoidance becomes sort of a theme song in their life. It sort of becomes their master, so to speak. It's kind of, I won't go places that might remind me of these things. I won't watch certain things on screens that could remind me. I don't want to interact with other people about this. I'm certainly not going to tell people about this. And they just keep radically amputating away parts of their lived experience, but also anytime something like that comes up, they try to avoid it. It's for this reason that individuals who suffer from PTSD also tend to have much higher rates of substance use disorders, because it's easy to hire substances to numb and avoid. Now, not everyone that has experienced trauma is going to have an alcohol use disorder or something, but that is a very effective avoidance strategy. You can hire that to do that job for you. And so basically, when we apply exposure principles to individuals who've suffered from trauma, we're inviting them to do the thing that they have been probably fairly consciously avoiding. And it is to deliberately face the vivid memories of what occurred. And then also in many exposure therapies, and not so much in written exposure therapy, but in many exposure therapies for PTSD, it's also sort of helping them to create that graded exposure, similar to the tarantula, to take back parts of their life. So are there things, relationships, places, things, whatever, that you've refused to do since this has occurred that would be important for you in order to build a meaningful life? And so a therapist will help someone to kind of set that plan. And in written exposure therapy, individuals are invited to engage in that exposure exercises, not so much by talking about it with a therapist or thinking about it alone in their own mind, but rather by writing it out. And so the therapist, through a series of prompts that are written from Marks and Sloan in their manual, over a period of 5 appointments, will literally write for 20 to 30 minutes at the speed of handwriting about the worst parts of the memory. It's sort of like, we're going to go straight there, and we're going to do it at the speed of handwriting, which I have found. Now, I will say that the Department of Defense and the Veterans Administration clinical practice guidelines, like they're no kidding, these are the best of the best treatments. They have recently sort of downgraded written exposure therapy from the tippity top to something that's certainly helpful, but probably not as helpful as something like EMDR, prolonged exposure, cognitive processing therapy. And frankly, I don't know why that is. I mean, it's a much newer kid on the block in terms of therapies. It's very different. It would not be there would be populations of people with comorbid mental health issues for whom written exposure therapy alone might not be a great option because it is so much shorter. Complex PTSD, for example, which is not something that we use in the States, but it's certainly a diagnostic label that's used in the International Classification for Diseases. There's a number of reasons why perhaps written exposure therapy would not be the best fit for incredibly complex cases. However, having used it a bunch with people 18 and up from the manual, I will say that it has been so effective for some of the people that have gone through the treatment process. And it's really desirable because it's only 5 appointments, whereas many other of these evidence-based approaches are 10, 15 sessions. It's a lot longer time and much longer duration of session visit. But I think written exposure therapy is a lovely example of how for some of these therapies, especially the exposure-based ones, individuals are actually asked to do something quite courageous. What I like about written exposure therapy, and we find this in some of the other approaches as well, I think there's a misunderstanding, perhaps rightfully so, among some people who are skeptical of therapy, saying, a never-ending exploration of self might not actually lead you somewhere desirable. And if you've ever had a friend or a relative who is obsessed with themselves, I think there's something to be said for that. I wouldn't want one of my girls to marry a narcissist or something like that. And I think, I don't know that many therapists are trained in that way. But I think, in practice, sometimes it's the function of the therapist is to help someone explore in evaluation of their history and their feelings and their thoughts. I don't know that that's always the highest thing that we might aim for, because simply, drawing deeper into the self just leaves something to be desired, in my estimation. And so in the final 2 of the 5 kind of written assignments for written exposure therapy, people are certainly invited to spend some of the time doing the hard work of exposure. Because again, if I have just fragmented memories of sensory details, sometimes I don't even have a coherent memory of what happened. And so it's extremely helpful from a healing process as creatures that long for coherence to try to understand what happened to me and what was I thinking. But in the final half of written exposure therapy, people are taking much more of a present and a future focus. And they're not asked specifically to write about post-traumatic growth or about, wisdom that was cultivated or about fresh opportunities, etc. But it almost naturally flows from the pen when people are slowing their processing down just to the speed of handwriting, where it's not just a fury. They're able to unpack really scary things in a methodical, logical way with the frontal lobe online, and it's not all just emotion. But also as they think about, I did experience that, and they're able to kind of think about how the fact that they have a present and a future. It's just been beautiful to kind of bear witness to individuals talking about how much more gratitude they have for relationships in their life now, or the kinds of things they might aspire to spiritually or relationally with those that matter the most to them. I think good therapy can be short term and powerful in terms of therapeutic rapport and all the relational factors involved in that, helping people to gain some insight, to learn, normalize, validate, experience something that might be useful in that very bizarre kind of relationship with a therapist. But then I think just as important as any bit of that is this kind of puts us in a position to no longer need a therapist and to move forward in our life, where we can be interested in making contributions in the lives of other people or aligned with our worldview.
I think what I've really appreciated about written exposure therapy, because I've been able to do a little bit of it in my time in my internship and my residency, and I think what's great about it is that the narrative process of understanding the past and understanding the present, so you can move towards your future, right? And I think what I've noticed is that there's a lot of patients sometimes might struggle with talking or describing their trauma, but it might actually be a lot easier for them to kind of just write. And it's the flow of the writing process that's so much easier for them. And I've also had a lot of patients tell me that they like written exposure therapy because there isn't really a lot of homework that they have to do afterwards, right? They just come into the session, they just jump right in, and it is so effective. And so I really appreciate that. Transitioning to cognitive processing therapy and prolonged exposure therapy, we kind of mentioned a little bit about the exposure part. And if you can speak to that in terms of the differences between those two modalities, cognitive processing therapy and prolonged exposure therapy.
Yeah, so fundamentally, these are all exposure therapies. And there's a lot of tribalism among these camps, depending on who's been trained by who, and everyone thinks they have the way, the truth, and the life. And I think that there's a lot of common threads. CPT and PE, or cognitive processing therapy, prolonged exposure, have definitely been around the longest in terms of like weighty empirical evidence for trauma survivors. Edna Foa did PE, and Monson and Resick did CPT. I think one of the profound differences, now these are two longer, 10 to 12 to 15 session, both of them, relative to written exposure, much longer, much more complex, both for the person providing the therapy and also for the person receiving it. Cognitive processing therapy is much heavier in cognitive therapy, meaning a much higher focus on the attributions, evaluations, and understandings that a person has in their thinking about why the trauma happened and what it means for them, for the future, for the world, for God. There's tons of worksheets that kind of help people to think about a core traumatic event and what their beliefs are about that, and whether or not their beliefs are even correspondent to reality or perhaps not. You're working in a VA right now. I did not meet many people who were enlisted in the military who said, I joined the military because I love homework, I love worksheets, I just can't get enough of those. And so I found in my military experience that seeing someone through the entire cognitive processing therapy manual, a dozen or more sessions, was pretty tough. A lot more fidelity, maybe in a group, because there were those group dynamics. And but it was a strange bird in the military that was like, I could really get behind that. Give me a dozen worksheets and I'm going to get after it. And I certainly met that person. When I was the director of emotional well-being at the University of Notre Dame and largely working with faculty members, written exposure therapy and cognitive processing therapy, because there is a bit of writing in cognitive processing therapy as well, particularly writing sort of about the index trauma, both at the beginning and at the end of the treatment modality. I mean, these were faculty members whose livelihood was dependent upon an unbelievable signature strength in their ability to write. Prolonged exposure doesn't involve as much of that. It's a lot more verbal expression of the exposure that happened. Both CPT and PE have that kind of real life exposure component to them. So you're doing a lot of the in your mind exposure work in the sessions or between sessions, but you're also expected to kind of create a hierarchy of things, starting with something that would require a small amount of courage and then building toward medium and large amounts, to sort of take your life back and to retake territory that's been given up to fear and avoidance. So, one of the cool things, if there are people that watch this, they're like, I don't really know what I'd like to do in terms of a career, but I know I'd like to be a psychologist, for example, or a social worker. Doing an internship or getting a job in the VA or the DoD allows you to get training in these things, usually at no cost or very, very low cost. It's an expectation that clinicians will be trained in one or both of those old school modalities.
Dr. Dell, do you have a personal favorite modality? I know we sort of talked about written exposure therapy. We talked about prolonged exposure therapy and cognitive processing therapy, and maybe a little bit of EMDR. But is there one that is maybe your go-to or your favorite?
Yeah, I probably would say among adults, and I've worked mostly with adults now for years. Um, I will often start with these shorter modalities, EMDR. So when that's studied in terms of outcomes, usually between 4 to 6 hours of EMDR, if it's going to be helpful, it has been. Although in my experience, you don't usually need to go 4 to 5 sessions to know whether or not it's going to be a good fit. In fact, um, Shapiro's eye movement desensitization and reprocessing therapy, I was enormously skeptical of it. Even in the training, I just laughed my way through it. I was quite disrespectful, actually. It was like one of those situations where you don't want to laugh, but you can't help it. I mean, I would watch these videos of the trainers, and I just thought, this is the biggest placebo thing I've ever been trained to do. And I thought I had a good handle on some of the dismantling studies associated with it. Dude, these eye movements do nothing. This is all just the exposure. And yet I would just say this. I worked with an incredibly international population of people at the University of Notre Dame. I mean, there are faculty and staff there from all over the world. And I just found, and this is entirely idiosyncratic, anecdotal to me, but EMDR was probably the most powerful modality that I used there. I probably did more trauma-oriented treatment with a more diverse population of people in those 4 years than ever in my career. EMDR was far and away the most powerful and effective. And written exposure therapy, those two were almost the only two that I would use, unless somebody had, tried one or both of those and they weren't effective. And I was really surprised by, and I still am, I do EMDR now sometimes with individuals who are geriatric in subacute rehab hospitals between here in Chicago, individuals who fell and had a catastrophic injury at the age of 90, or laid in the ground in their, apartment for a day and a half and got rhabdomyolysis, or, traumatic type events for individuals. And I'm just always, I'm still surprised by the strong sensory responses that sometimes people have with EMDR, where they'll feel certain things rise up in their bodies as a result of doing this, or they'll have almost an immediate response. People have fallen out of chairs. I wouldn't recommend that for the 90-year-olds that I'm seeing in that. For example, an individual processing a very bloody and traumatic loss of a baby at birth, who 3 seconds into EMDR doubles over because she's cramping. Or individuals who experienced, a blast injury, who in the very first session of EMDR are having vivid, strong sensory things in the parts of their body that were injured. It's just, it's a powerful thing. And I think it helps people connect in a way. Now, there's various theories as to why it's helpful. But again, I just think, listen, if my shtick was, and I'm kind of a generalist, in terms of being a clinician, but if I was only working with people who had depression, well, I would want to know several different approaches in the clinical practice guidelines that are helpful for that. I'd want to know interpersonal type approaches to psychotherapy, and, acceptance and commitment therapy, or cognitive behavioral therapy. I would want to know some of these, such that I could be flexible, and I could have some variety and more than a single string on my banjo. But also so that, for someone for whom therapy is not, this particular therapy isn't a good fit, I can very quickly pivot to something else.
Right. Yeah. I think what's kind of going through my mind as I think about all of these modalities and treatments, written exposure therapy for the writing process and kind of the narrative flow, cognitive processing therapy to kind of with those sticky maladaptive beliefs that maybe it's not a 180 turn in terms of getting rid of those beliefs, but at least they're less sticky. At least they're less, maybe more in the gray. They're not as black or white. And then prolonged exposure therapy with really helping the patient really kind of take back their life, because avoidance does make your life so small, right? You're not engaging in social interaction. You're not going outside. You're not engaging with the fear. And then essentially EMDR, I like that somatic aspect, the somatic sensory connection that you can see with EMDR, where people are actually connecting to their bodies, what the trauma is doing for them. And, I'll never forget, there was one of my mentors talked about how trauma is kind of like a shark, like in the ocean, and so many fish swim away from the shark. And that's the thing that the shark is used to. The shark is used to everything swimming away from it. But in trauma, even when you watch these shark movies or these Shark Tank videos, when a human gets into the shark tank and they put their hand on the nose of the shark, they can push it away. And whenever something confronts the shark, it kind of gets confused and bewildered. It's kind of like, what's going on? And I very much think of trauma like the shark, in that the more you avoid, the more it'll just follow you. It'll just chase you through life. And I've had patients over decades who have experienced trauma, and yet they still get these significant nightmares, these flashbacks, but yet when they engage in treatment, there's a sense of them putting themselves in the cage, putting their hand on the nose of their trauma and kind of pushing it away to diminish the sense of power that it has over their lives. Is there anything that you've seen in the research in terms of future modalities or technology or new ways that clinicians can help patients deal with trauma?
Yeah, if we were to do something like this in 10 or 20 years from now, it would be all completely different stuff, I think. And so really the history of medicine, and certainly the history of our little infinitesimally small, very short-lived discipline would suggest that in 20 or 30 years from now, they're going to look at what we're doing as kind of barbarism, or certainly not very helpful. And so I think we should be kind of humble about that. There is increasing evidence. So I guess I would say, in terms of clinical practice guidelines, this is one of the rare exceptions in all mental health conditions where therapy tends to be first line and not medicine, or not the combination of the two. So, it depends on which ones you read, but in some of these kind of authoritative, what really works for whom and why, therapy kind of leads the charge for trauma survivors. Medicine can be helpful, but oftentimes therapy alone is sufficient. There's some very interesting research being done with all sorts of stuff that makes some people quite uncomfortable, psychedelics or even things like ketamine or whatever. There's lots of different approaches that I'm extremely open to. I think different modalities are going to come, and hopefully we're going to put them to the test and examine them carefully, and hopefully find ways to better resource the world, where we know that lots of people will get exposed to trauma, and a smallish minority of them, 25% of the world's, for at least a time, is going to be really disturbed by what happened. And if there's ways for us to expedite early intervention and prevention in a world where trauma is ubiquitous, I'm all for it. And so I think that we'll increasingly find all sorts of technologies, and even alternative and integrative medicinal, psychopharmacological type interventions that are going to come to bear.
Yeah, I think one of the things that I had seen was there were certain places incorporating VR in regards to prolonged exposure therapy. In fact, even some VAs have done that. And so having patients take on this VR set and kind of go through the imaginal process, but maybe in a more of a kind of like a in-your-face type of way. And I thought that was really super interesting, but I agree. One of the things that I think is really important to also talk about, and you also kind of highlighted it a little bit in the beginning, is the sense of vicarious trauma, in that we as clinicians, we are taking on a lot of the weight, and I think a lot of the burden of these patients' stories. And how, as a clinician, how do you deal with that?
Yeah, I think that's really a thoughtful thing to think about. And far too often in my professional experience, I'll go to a conference and, that will either be a total omission or very much kind of an afterthought. Now, a lot of times we go to conferences not only to think of ourselves or whatever, but, I would say for all humans that healing actually can come in manifold ways. So, recently, last 10 years or so, Bessel van der Kolk is a fairly well-known name in the trauma treatment communities, trained as a psychiatrist, wrote a pretty well-read book about the body keeping the score. I have a lot of respect for him. I don't know him at all, but I have respect for the fact that as a trained psychiatrist, he has been trained in psychotherapy approaches to trauma treatment, but also, at least at one point in time, championed the largest randomized controlled trial for yoga as an intervention for trauma survivors. And I think all grace comes from God. Some people might find that what is far more therapeutic than multiple approaches to therapy is significant ways to contribute and belong in a faith community, for example. And for others, it might be, trauma turned me upside down, gave me symptoms I couldn't really control. And that started me on a path of self-compassion, which was less about telling myself nice things and rather about living a wise, self-controlled lifestyle in terms of nutrition, movement, sleep. And as a result, right, I've lost a huge amount of weight and my inflammation is way down and my gut health is much better. And frankly, I don't know which of those things helped, but I feel very different. I mean, I've heard that story a lot in therapy, at which time I oftentimes tell the person, like, you don't need therapy, keep doing that thing. Deep friendship, like the kind that Aristotle wrote to his son about. These things, I think, while not being therapy, are potentially so much more impactful longitudinally over the course of someone's life. And so those are the kinds of things that I peddle professionally. I mean, I'm trying to get myself fired as quickly as possible, not fired because I've failed someone, but largely because they don't have any use for me anymore. They've run to the end of my competency after half a dozen sessions, probably anyway, because I'm not an AI bot. And, my hope would be that whatever good I could offer to them would happen quickly, and then they could be more meaningfully connected to real relationships and not a clinical one, and meaningful life building that they are able to direct, et cetera. So I guess I just think that seems so abundantly clear to me as a clinician, and it's really important that I reflect that in my personal life. So there's been times in my life, right, where I came to realize, like, I'm hiring alcohol to do certain jobs for me. And it doesn't even take that much alcohol use to meet a mild alcohol use disorder diagnosis. It's like sometimes I drink more than I mean to. Other people think it might be a bit of a problem. And I've developed some tolerance over the years. Like, it takes more for me to get drunk now than it did when I was 18. It's like, well, that's a mild alcohol use disorder. So it's like, oh, okay, well, probably I should stop doing that, right? And I'm very intentional about nutritional science and exercise. And I'm dressed like this because I just got back from a 10-mile bike ride with my daughters, toting them behind me. I try to find ways, right, that are more than bubble baths and scented candles, to be able to reflect over the course of my life on most days to say that I lived on purpose when I swung open the refrigerator. And, personally for me, I think it has a lot to do with spiritual discipline and sort of a sanctification process whereby I increasingly become conformed through communion with God, and then my own, volitionality when I choose to walk in that direction, to become a richer, fuller version of human, and hopefully to be a good dad and a good husband. And so,
Closing out, Dr. Dell, this has been such an amazing conversation. And I think I'm reminded of maybe two big points that stick out to me about this conversation. One is that regardless of trauma, there is hope, there is resiliency, there might even be post-traumatic growth from someone's situation. And, a story I didn't mention, but I had a mentor who was seeing a patient, and the patient was talking a lot about their dreams, the nightmares that they were having. And over time, the psychologists themselves actually started to actually experience the same nightmares for themselves, which was so interesting. And, the psychologists had never witnessed the trauma. They had never experienced the trauma. They were never directly there in the trauma with the patient. And yet over time, through listening to the trauma, listening to the patient talk about their trauma and process their trauma, it was almost as if the psychologist was bearing the weight of the trauma for the patient, and they themselves started to have the same nightmares. And I think, what you mentioned, it makes me think about vicarious trauma, and that for clinicians, we do carry this weight. We can sometimes carry this burden for patients, and it's so important for us to make sure that we take care of our physical, our mental, our psychological, our spiritual health as well. That we as human beings are made to go through trauma. Like the majority of people can overcome trauma, but we can also bear each other's trauma. It's almost, I think that's amazing. The resiliency for people who have experienced a trauma don't necessarily get traumatized, and the people who do get traumatized have a sense of hope and resiliency in overcoming their trauma. And for the people working with those patients to help them with their trauma, they can sometimes carry it in a way that they're literally carrying the burden of that patient's trauma. And, I think one of the things that I want to think about for you, and one of the questions that I wanted to ask you is, the work that you're doing, whether physically, mentally, spiritually, how do you sustain yourself? How do you carry that load and that burden for your patients by taking care of yourself as well?
When it comes to trauma exposure, the types of trauma that tend to have the highest prevalence rates of PTSD are interpersonal betrayal traumas. So a natural disaster is a terrible thing, and some people will develop PTSD from that. Being raped by your dad has more potential for someone to develop PTSD. Like, this is someone that I loved, knew, trusted, and then they violated me in unspeakable ways. And so we know that, we know that there's something about being human in a trauma-infused world, where we are particularly vulnerable to be marred by interpersonal betrayal. And similarly, I think where the malady is oftentimes where we can find something curative. And without a question, it has been in the context of deep friendship relationships, becoming a father, caring for my daughters, being loved, and loving my wife for 18 years. And then, something spiritual, relationship with the divine. Those relationships are unquestionably the biggest sustaining factor in my life, such that I might have a really difficult day at work, or even be told by a client, and it's happened a bunch, you're the worst counselor I've ever met. And not just because you have a terrible hairline. Or, I've worked with people who've died by suicide, like while I was working with them. You do this work long enough, right? And you come to realize, I won't help everyone. And I'll witness things where the story doesn't get better, and then they kind of move on. And so I think, when our world is so large that, for example, at an identity deep level, we can be a child of God or have some sort of an affiliation to the transcendent. And then looking left and right, there are people in our lives that aren't only there because they need help in a clinical sense, but because you're their dad, or you're their husband, or you're their brother, you're their, fellow comrade in a faith community. That is the most medicinal thing. And so that's what's sustaining. It's bike rides, and it's jumping on trampolines, and it's faithfulness to a marriage, and it's, there's an ancient passage I'm particularly fond of, with a bunch of admonishments for how people in a faith community might live. And it says something like, love should be sincere. Hate what is evil, turn away from that. Cling to what is good, and be devoted to one another in love, and honor one another above yourselves. Never be lacking in zeal, but keep your spiritual fervor serving God. And then there's this triad, which I hope, at my funeral, someone might not say this exact thing, and yet I hope that these things will have marked my life. To be joyful in hope, patient in affliction, and faithful in prayer.
Dr. Dell, thank you so much for your time, your guidance, your insights. I think this has been a really wonderful conversation about trauma, and hopefully provided the audience just a little perspective of what life could be like for future clinicians as it relates to trauma-informed care, and maybe even some excitement. And I also think that even looking at this career from the perspective of the deep-rooted work that it is, but also the meaningful work that it is as well. And so I really appreciate you sharing your perspective and your experience. Yeah, thank you.